Hello, everyone. I'm Sarah Garrett. I am faculty at the Philip Arley Institute for Health Policy Studies, and I have the pleasure of introducing our wonderful Grand Round speaker today. Thank you all for joining. Today we have Dr. Katie Bacchus-Casamano speaking with us today. She is a distinguished McKnight University professor in the Division of Health Policy and Management, University of Minnesota School of Public Health. She is co-director of the University of Minnesota's Rural Health Research Center and the University of Minnesota's Rural Health Program. Dr. Casamano earned a PhD at Harvard University, an MPA at the Princeton School of Public and International Affairs, and a BA at the University of Minnesota. Dr. Casamano conducts research to inform health policy that supports people at critical times in their lives, including pregnancy and childbirth. Referencing her research and recommendations, new local, state, and federal laws have allocated resources to improve access to evidence-based services for pregnant people, parents, infants, and families in communities that have long been affected by persistent inequities. Dr. Casamano teaches courses that build skills for engagement in public health programs, policy, and research, and she works extensively to engage with and inform leaders with the power to improve health and well-being of individuals, families, and communities starting at birth. We are so pleased and honored to have her join us today. And I will invite everyone to log their questions in the Q&A box. You can do it at any time, and then we'll take those at the end. Thank you so much. Dr. Cosmano, go ahead.
Hello, everyone. Good afternoon. I'm really grateful to be here. Thank you to Dr. Garrett, to Sarah for the introduction, to Dr. Spetz for the invitation to come and speak with you today. And I'm grateful to each of you to have the chance to be here and to be in conversation with you about intimate partner violence around the time of the perinatal period. Katie Bacchus-Casamano Indigenicas, Ajijak Ndudem, Wenji Majijiwang Indujiba, Germany, England, France, Indujiba, Mato Bade Inda. I am Katie Bacchus-Casamano. I use she, her pronouns, and I am descendant from people that come from the area of northern Minnesota known as Wenji Majijiwang, which is a part of the White Earth Nation. And I'm also descendant of people from Germany, England, and France. The land that I am working on right now is Dakota land. And I also want to move into this conversation today to ground us in where we are and the people and families that are where we are. So again, I acknowledge my presence on Dakota land, and I also acknowledge and honor the Ramaytush Ohlone people, who are the traditional custodians of the land that UCSF sits on, which is their home. I encourage everyone to consider that Indigenous people, especially Indigenous women, experience disproportionately high rates of violence, including intimate partner violence and maternal mortality. The context of today's discussion relates to violence, and they're more common than most folks would imagine. I encourage folks to take care of yourselves as we move through this. Many of us are or know people who have been affected by intimate partner violence, by family violence, and by other topics. And so I encourage all of us to be careful and kind to ourselves and one another. I also would like to begin by acknowledging my teammates and co-authors on this work at the University of Minnesota, Julia Interrante, Emily Sheffield, and Alyssa Fritz. At UNC, Valerie Lewis. And I'm also grateful to my colleague, Dr. Lindsay Adman, who is at the University of Michigan. I want to also acknowledge, for this study, the studies that I'm going to discuss today, we use data from the Pregnancy Risk Assessment Monitoring System. And I appreciate the participants in that survey, what they shared about their lives. And I want to hold that with honor and grace. Whenever we are conducting analyses of data, it is important to remember the people behind the stories, especially when the stories we are telling and the data we are gathering is about things as precious as birth and things as terrifying as experiencing intimate partner violence. I also acknowledge survivors, including those on our study team and those in our midst today, those with stories told and untold, those with experience and those who are alive and those who are not. This is a difficult topic, but giving voice to the truth helps us to allow for change. In our time together today, I have several goals for us. I'd like to provide context on rural-urban disparities for birthing people. So I'm going to focus on intimate partner violence in the context of perinatal health. Um, so I really want us to understand what life is like for birthing folks in rural and urban areas and what we know from the data about that. And then I'm going to get into some of the research that we have done on rural-urban differences in reports of perinatal intimate partner violence and in receipt of screening for abuse around the perinatal period. Among rural residents, I'm also going to focus on differences by race and ethnicity and by health insurance status. So within rural communities, there's a diversity of people, and it's important to understand among rural areas who are the most vulnerable. And at the end, I want to take time to bring in the voices of those that work on intimate partner violence prevention and support, and discuss potential policy solutions for increasing safety, hope, and healing, which I believe all people deserve. We will start with some of the sad stuff. We all know that the US has a maternal mortality problem, not just a problem, it is a crisis, and too many moms are dying. The data are shown here indicate how pregnancy-related mortality ratios differ across geography. And this is true with pregnancy-related deaths higher among the most rural residents generally, even after controlling for clinical and sociodemographic predictors of maternal morbidity and mortality. These disproportionate deaths are not an accident. They are mostly preventable, and they reveal inequities that can be rectified. Being healthy and safe during pregnancy, childbirth, and the postpartum period is a challenge for residents of rural communities. This has long been true and continues to be true, with headline after headline indicating loss of obstetric services in rural communities, workforce shortages, financial challenges, and safety concerns. Growing risks of maternal morbidity and mortality in many communities, including elevated risks for rural Black and Indigenous people and families. I want to take a moment to pause on language because I believe language matters. And in maternity care, the very language that we use to describe this problem, including the terminology maternity care desert, it points to the errors we are making in tackling it. First, naturally occurring phenomena such as deserts are distinct from structurally designed inequities that result in medically underserved areas. The term maternity care desert obscures the deliberate policy decisions that leave some communities without access to care while others do have care. Additionally, the word desert used in this context is used to imply a vacuous and empty space. And the US deserts are thriving environments that have been home to Indigenous people for thousands of years. Indigenous people, especially those living in rural communities, have among the least access to maternity care. So using the term desert in this context, implying that there's nothing in a place, it's not only inaccurate, but it's a cause of further harm and erasure of Indigenous folks. It would be more accurate to describe places without maternity care as a place without maternity care or community without maternity services. That is explicit, and it directs attention toward the decisions and structural inequities that leave some communities without access to care. This is happening in maternal mortality. The use of the term desert also focuses on healthcare systems as the sole place to rescue moms from maternal mortality, and it implies a helplessness about the situation. Maternal risk does not just derive from lack of access to clinical care and services. There's risks in homes and communities as well. Far from being a naturally occurring thing, maternal mortality that results from a confluence of violence and lack of systemic support, including access to healthcare, is ripe for prevention and for investment. As I noted, access to maternity care has been in the decline in recent years, and we have recently published updated information on access to hospital-based obstetric care in rural and urban areas. Data for both analyses came from the 2010 to 2022 annual or American Hospital Association annual surveys, as well as the CMS Provider of Services file. We also use the HRSA Area Health Resource file, and we use a very rigorous validation methodology to follow up to correct any errors that happen. And that methodology brief has been published and is linked here if that is something that is of interest to you, of figuring out which places do and do not have access to hospital-based obstetric services. There are several widely based or widely available and highly visible different types of metrics that are used. And they can be very useful for the things that they cover, but are not always fully accurately capturing whether or not a hospital has obstetric services and when those services ended, if they did. So here's a figure that tells a story that's pretty straightforward. Basically, what we see is the percentage of all rural counties with county-based, with hospital-based obstetric services in those counties has been declining and is continuing to decline over time. If we look at among rural counties only, there are, I'm going to use some technical terms here, micropolitan and non-core counties. Micropolitan counties are, you can think of them as non-metropolitan counties that have a small town in them, a town of at least 10,000 people. A non-core area does not have a town of 10,000 people. And then we're talking about counties here, which is also limited, right? Because we have, you all know in California, right? We have some counties that are extremely large and others that are small. And when you call a whole county by one determinant, it can, there's variability basically within those counties. But when we look at the places with small towns versus those places without, we can see a huge difference. We see a decline in both places, but fewer than 25% of non-core rural counties, our most remote rural counties, have access to hospital-based obstetric care. And again, we will also talk about this, but I want to hold that in the context of all of the other things that the most remote rural counties also do not have access to. When we look nationally, now this is showing a different direction. We're showing an upward trend, and this is the percent of hospitals. So this is, we're not looking at counties anymore. We're looking at hospitals in rural and urban areas, and nationally, that's the boxes in the middle, that do not have obstetrics. So this is the percentage of short-term acute care hospitals without obstetrics. You can see the top line here, the circles, is rural areas. And now it's at 52% in 2022, the latest number that we have, or the latest data that we have on that. More than half of all rural hospitals do not have obstetric care. More than half, and these are of the ones that are open because we know they have been closing too. More than half of all open rural hospitals do not have a place where someone can give birth. And again, the overall number of these, the denominator here, is going down over time as well. So this shows, and we can see this happening in urban areas as well. So we basically have a lot of places where you can't access birth. And there are other things that go along with this. Besides just being able to have a baby at this place, this also means access to prenatal care services, the augmentary services and supports, whether it's social work support or nutrition services or lactation support, doula care, many of the things that help people, mental health services and supports for people around the time of pregnancy and childbirth. Those can go alongside. Obstetric unit closures have consequences. We've studied this. There's lots of research on this, but they include increases in a range of like preterm births, emergency room births, travel distances, use of cesarean delivery. However, access to health care is not the only thing that pregnant people need to be healthy and safe. People need to be free from violence as well. Intimate partner violence, which is abbreviated IPV, encompasses acts of physical, sexual, and emotional violence by an intimate partner seeking to gain power and control. This can include emotional abuse, economic abuse, sexual abuse, intimidation, and isolation. Violence is one of the most common health concerns reported by people who are pregnant in the United States. In addition, domestic violence, including intimate partner violence, is a leading non-obstetric cause of maternal morbidity and mortality. While physical violence is a commonly recognized form of intimate partner violence and will be the focus of a lot of the data I discussed today because it's what's measured, emotional and sexual violence are also harmful and prevalent. I want to give you some examples of those now. And again, please take care of yourselves if this is difficult to hear, but I think it's important to consider pregnant people in rural and urban settings who experience these things and the harm that that may do to their health and well-being. And this includes verbal insults, humiliation, isolation from friends and family, threats of harm, control of finances, monitoring their communication or location, um, sexual violence, including forcing or attempting to force a partner to take part in a sex act, sexual touching or non-physical sexual events like sexting when a partner doesn't or cannot consent. Pregnant people in rural communities face risks that render them more vulnerable to intimate partner violence and its consequences. This includes more firearms, higher injury rates overall, fewer legal resources, fewer health services, fewer shelters, and fewer support services. There's also, as I mentioned, higher risk of maternal morbidity and mortality in rural compared to urban communities, and higher risk of losing access to obstetric care. Maternal experiences of intimate partner violence are associated with higher rates of preterm birth, lower birth rates, and lower rates of breastfeeding. Risk for the most severe outcome, which is intimate partner homicide perpetrated by an intimate partner, is heightened around the time of pregnancy and childbirth. 60% of the homicides that occur around the time of pregnancy are related to intimate partner violence. Universal screening is recommended since 2012. ACOG has recommended screening during pregnancy and postpartum, and the U.S. Preventive Services Task Force upgraded their recommendation to universal screening in 2018. So everyone should be screened during pregnancy, well, before pregnancy, during pregnancy, around the time of childbirth, and postpartum. Data from research by my colleague, Dr. Maeve Wallace, highlight the risks people face around the time of pregnancy with real data from the state of Louisiana. She and her team have analyzed records from Louisiana's Maternal Mortality Review Committee that show the causes of deaths. Dr. Wallace's research has also shown that in Louisiana, a law to keep guns out of the hands of abusers, often termed red flag laws, was associated with reductions in pregnancy-associated homicide. It keeps birthing people safer. The graphic and headline below are from the December New York Times piece. It was one of several emerging media stories on this topic, and I'm so glad to see the media paying attention to this important issue. Homicide deaths are usually omitted from maternal mortality statistics because they aren't considered sufficiently related to the pregnancy itself. But homicide isn't a rare outcome for pregnant and postpartum people. It's one of their leading causes of deaths. So this makes pregnancy-associated homicides, as they're called by epidemiologists and health researchers, a real public health concern. And though homicides aren't generally classified as pregnancy-related, the pregnancy often plays a part. In these cases, it's a husband or a boyfriend that's often a killer. And the stress and emotional turmoil of pregnancy, especially an unexpected one or sometimes termed unwanted pregnancy, can exacerbate an already abusive relationship. According to experts on intimate partner violence, the abuse almost always precedes the pregnancy. The research project that we conducted focused on the rural context. We looked at describing rural and urban differences in the prevalence of intimate partner violence, and we took a focus on rural residents and disparities among folks who live in rural areas. We used both qualitative and quantitative methods to assess how screening and support services could be improved to support rural and urban families during pregnancy and the postpartum period. The terminology that I'm going to use here, I have used both intimate partner violence and domestic violence. The terms domestic violence is often used in legal literature and in criminal proceedings. Intimate partner violence is used more frequently in public health and healthcare, and so that's what I'm going to use here. Another term that I'm going to use is victims. And there's a lot of discussion about how to use that terminology. A lot of folks prefer survivors, but not all victims survive. So I want to also acknowledge the folks that experience intimate partner violence and that don't survive. So I will be using that terminology and recognizing that there are other terms as well. But I would also like to follow the lead that's been set by Giselle Pellicott, who experienced horrific violence at the hands of or sexual violence at the hands of her now ex-husband, but that using the term victim the shame should change sides. And just because you were a victim, that shouldn't be a shame holding, that should not be a shame holding terminology. But anyway, for folks, just to give some context around how we consider the words that we use, because as I mentioned earlier, language matters. Okay. So we used 2016 to 2020 data from the Pregnancy Risk Assessment Monitoring System, PRAMS, which is a survey of US residents who recently gave birth. The sample is representative of over 80% of births in the US. One important caveat, the state of California is not included in this. So for those of you who reside in California and are thinking about this, I think this is broadly representative data, but they do not include folks in California. There may be specific, I'm certain there are specific issues in your context that would be important to look at. This analysis focused on two outcomes: whether respondents reported experiences of physical violence by a current or former intimate partner, and whether respondents were screened for physical or emotional abuse at their healthcare visits. Intimate partner violence includes physical, emotional, and sexual violence, and the measures available in PRAMS only include experiences of physical violence and screening for physical or emotional abuse. Ooh, sometimes it just wants to jump ahead on me. I'm sorry about that. So we used the survey questions that we used are listed here, and you can see the language that is used in them. To measure experiences of intimate partner violence, we used the PRAM survey question that asked whether the respondent had been pushed, hit, slapped, kicked, choked, or physically hurt by a husband or partner or an ex-husband or ex-partner. To measure for those who were not screened for abuse. So we measured non-screening as a measure. We wanted to predict what made people at greater risk and who we needed to focus on. So it's always hard to figure out how to measure variables, but that's how we did it here. We used the PRAM survey question about healthcare visit attendance and abuse screening. Respondents were first asked whether they had any healthcare visits in the preconception period, so in the 12 months prior to pregnancy, any prenatal care visits that happened during pregnancy, and almost everyone in this sample has prenatal care, or a postpartum checkup visit between childbirth and the time of the survey. And most folks responded to the survey between 2 and 4 months postpartum. If respondents reported having visits during these periods, they were then asked whether a healthcare worker asked them at that visit if someone was hurting them emotionally or physically. And again, we focused on lack of abuse screening in this analysis. We used logistic regression models to compare key outcomes for rural versus urban residents. We used these models to estimate rural and urban residents' predicted probabilities of experiencing physical intimate partner violence, and we also estimated their predicted probabilities of not being screened for abuse. We did that overall, and then we also did that specifically among those who experienced intimate partner violence. When we looked at people who, now these are folks that have experienced physical violence around the time of pregnancy and were never asked, were never screened. We looked at two potential reasons why. One, it's because they didn't go to a visit. They never saw a provider, so they weren't screened because they weren't able to. And two, folks who went to visits but were never asked, because distinguishing those two things implies something different about what we should do about it. Our sample is listed here. We had over 200,000 folks total and about 8,000 people who were victims of physical intimate partner violence in the perinatal period. More rural residents experienced physical violence by an intimate partner than urban residents. The figure at the right shows these proportions. So it's 4.6% of rural residents who gave birth reported physical intimate partner violence and 3.2% of urban residents. Sometimes these numbers seem small. Let's be clear about a couple things. This is only the physical portion of the kind of violence that are the kinds of components of intimate partner violence. And also, there are approximately 4 million people who give birth every year. 1%, 2%, 3%, 4%. When you apply that across a population that big, that is so many families that are affected. That is so many families that are affected. Our analysis also showed that rural birthing people were more likely to experience physical intimate partner violence than their urban counterparts across a range of characteristics. So the figure on this slide, you don't need to look at all the numbers here. The point here is that the blue bars, which are rural residents, have higher rates of intimate partner violence generally than the urban folks that are shown in orange here. Across most measured characteristics, rural residents had higher predicted probabilities. I'm going to zoom into this a little bit more when we start to look at specific groups. Where are the rural-urban differences the biggest? So rural residents who identified as non-Hispanic white, Hispanic, and primarily English-speaking, and American Indian Alaska Native had significantly higher predicted probabilities of experiencing physical intimate partner violence. And compared to their peers who were urban. Okay. So for these three groups of people, the rural urban divide was very large, or significantly large. Same for younger folks. So rural residents who were 18 to 34 were more likely to experience physical IPV than urban respondents in that same age range. And Medicaid beneficiaries in rural settings were more likely to report experiencing intimate partner violence compared to urban Medicaid beneficiaries. Now we are looking just at folks who experienced intimate partner violence, who experienced IPV. IPV victims are not being screened for abuse during all the stages of pregnancy in the perinatal period. Non-screening for abuse happens both because birthing people are not attending healthcare visits. And I don't want to say this in a blaming way, right? Because I think we do this a lot to pregnant people and to people in our healthcare system. We call them non-compliant with visits, but there's maybe a very good reason why they are not coming in. And if they're experiencing intimate partner violence, there may be very good reasons why they are not able to come in. So they experienced non-screening both because they didn't attend visits and because they weren't asked at the visits that they attended. So here you can see our blue and orange are a little different in this chart. So the blue represents folks that did not have a visit. These are people who experienced physical intimate partner violence and were not screened because they did not have a visit. However, in the orange, we see folks that are intimate partner violence victims who showed up for a visit prior to, during, or after pregnancy and were never asked whether or not they were being hurt physically or emotionally. All of these rates are too high, obviously. They're too high among both rural and urban intimate partner violence victims. Like you can see, I'm sorry, rural folks are on the top, urban folks are on the bottom of this. So I didn't do all the orienting before I started jumping into being angry about the people that are not getting screened because it matters so much. But more than 2/3 of rural and urban intimate partner violence victims were not screened for abuse during the preconception period, in the time period before pregnancy. And as we may recall from an earlier background slide, oftentimes people that experience intimate partner violence during pregnancy, the abuse precedes the pregnancy itself. About 1/3 of rural and urban victims were not screened for abuse during pregnancy, and more than half of rural intimate partner violence victims and almost half of urban IPV victims were not asked about abuse at their postpartum checkup visits. 20% of rural respondents were never screened for abuse. This is overall, not just among IPV victims. So this is not shown on the slide, but I just want to tell you more than 20% of rural respondents were never screened for intimate partner violence, either preconception, prenatal, or postpartum. And that was about 16% for urban folks. This is just like shocking to me. During each stage of pregnancy, a higher proportion of rural IPV victims were not screened for abuse. But these numbers highlight a clear need for increased abuse screening at healthcare visits for all birthing people and implementation of universal screening recommendations. So this slide goes into a little bit more detail about the rural and urban folks with specific characteristics that had higher predicted probabilities of not being screened for abuse. So again, you can see in a lot of cases, now these are overlapping confidence intervals in lots of cases because we start getting smaller sample sizes. But we see higher rates of non-screening among rural folks compared to urban folks on point ranges. Across some of the measured characteristics, rural residents had significantly higher predicted probabilities, but not universally, again. I'm going to here zoom into for which groups of people is the rural-urban difference the most pronounced. As it was with rates of intimate partner violence, so it is with screening and lack of screening among Medicaid beneficiaries in rural places. So among victims of intimate partner violence, rural Medicaid beneficiaries had significantly higher risk of not being asked if they were being hurt compared to urban Medicaid beneficiaries. Also, rural victims who were between 18 and 24 years old were more likely to not be screened for abuse than urban victims in the same age range. And finally, rural victims who were not married at the time of birth had higher predicted probabilities of not being screened for abuse compared to unmarried urban victims of IPV. This study reveals that intimate partner violence before or during pregnancy is more common among rural residents compared to urban residents, and among those who experienced intimate partner violence, a higher proportion of rural residents were not screened for abuse at all during the perinatal period, and also specifically during the preconception period and postpartum period. There were very high rates of not going to visits and also not being screened at the visits that you were there. But still, more than 1 in 5 rural IPV victims was never, ever, ever asked at any visit they had during the perinatal period about whether or not they were being abused. Approximately half of homicides that do occur during pregnancy are related to IPV, as I mentioned, and available data indicate that Black birthing people experience the highest risk of pregnancy-associated homicide. Also, American Indian Alaska Native folks experience the highest rates of intimate partner violence overall, and data reporting practices frequently eliminate American Indian Alaska Native folks as a racial or ethnic category. This may undercount pregnancy-associated homicides among Indigenous folks. We do know there are racial inequities in access to maternal health care among rural residents. And we wanted to look more closely, given the data that we have about intimate partner violence, experiences of violence, and racial inequities in maternal health generally. We wanted to look at racial and ethnic differences in reports of intimate partner violence and postpartum abuse screening. So this one really focuses on the abuse screening in the postpartum period among rural folks. So we're looking at racial differences among rural folks. What we can see here is overall much higher rates of intimate partner violence among American Indian Alaska Native rural birthing folks compared to non-Hispanic white rural respondents. The multiple and other group also experiences an elevated risk, and some other evidence indicates that there may be a mixing here of folks that are Indigenous and are classified either as American Indian or in the multi or other category, but it's always hard to make an interpretation about an other racialized category. Results for screening were different. Among rural birthing people, non-Hispanic white birthing people had higher rates of not being screened for abuse compared to Black, Indigenous, and people of color. This includes those who were not screened because they didn't have a visit, and that there was heightened risk for that. Here again, you can see by the colors of the bars in the table. The yellow bars are the maroon bars are they didn't go to a postpartum visit, they didn't have a visit. And you can see that that is particularly high among American Indian, Alaska Native folks and Hispanic Spanish-speaking folks. And then you have those who were not asked about abuse at the visits that they attended. And that risk was much higher for non-Hispanic white folks. So these are folks that are going to visits and are not being asked about whether or not they're safe. These highlights show how racialized patterns of access to care and implicit bias among providers may manifest in risks to all racialized groups and emphasize the need for both prevention and screening efforts that are universal and reach all individuals in all different communities. I think it's really interesting here where when we see folks that are racialized non-white, that there's a much lower risk of not being screened if you get in for your visits. So but provider bias shouldn't be playing a role here at all when universal screening is what the recommendation is. As I have described, intimate partner violence is elevated among rural folks. Postpartum health insurance expansion efforts are part of what could potentially address multiple causes of maternal morbidity and mortality, including intimate partner violence. So we've talked about folks that are not getting access to postpartum care, and a lot of that was, remember, this is the study period here is 2016 to 2020. So it's before there was a lot of Medicaid expansion and before the public health emergency related extensions of Medicaid were put in place. So it actually gives us a good opportunity to look at how things are different for folks with different types of health insurance coverage and for folks that are churning in and out of coverage around the perinatal period, which we know can be a challenge and is something that we will need to be thinking about again if policy considerations on the table include cuts to the Medicaid program. So again, we use data from the 2016 to 2020 PRAMs, and we assessed self-report of experiencing physical violence by an intimate partner and rates of abuse screening at postpartum visits by health insurance. We looked at health insurance at childbirth and postpartum, and we categorized health insurance as private insurance, Medicaid, or uninsured. Medicaid, we excluded people with other types of insurance from this specific analysis. There were some small other groups there, but this helped us to really look at those. Those are the biggest groups, and to look at the changes in terms of churn across the insurance period or across the perinatal period. We measured insurance transitions. We looked at folks who had continuous private health insurance, continuous Medicaid, and people who transitioned from having Medicaid to moving on to private insurance or Medicaid to becoming uninsured in the postpartum period. So we found that intimate partner violence varies by health insurance status at childbirth, with the highest rates among Medicaid beneficiaries. So that's 7.7% of Medicaid beneficiaries saying that they experience these are folks, rural residents who had Medicaid coverage at the time of childbirth. And gosh, 7.7% of people is so much experiencing physical violence before and during pregnancy. And this compares to those who were uninsured, it's 1.6%, and those who are privately insured, also 1.6%. The trend was similar by health insurance postpartum, which you can see. So the top level here is insurance at childbirth. The second level is insurance postpartum. We see, again, higher risks among Medicaid folks, but we see also elevated risks among those without health insurance. And then if we look at insurance transitions, we see folks with continuous Medicaid coverage having the highest rates overall. But then we see folks that transition from Medicaid to private insurance or from Medicaid insurance to being uninsured, also having higher risks of intimate partner violence. Basically, folks that are being cared for by the Medicaid program, either at childbirth or in the postpartum period, are at elevated risk for physical intimate partner violence among rural folks, among rural residents. Half of rural residents lacked postpartum abuse screening, and this was most common among folks that were uninsured at childbirth and postpartum. So this shows here, again, we have the first line is all rural residents. Basically, were you screened at all postpartum? Again, we've got the not screened because you didn't have a visit in blue, and not screened because you went to a visit and were not asked in orange. And that label is not on here, so forgive me for that. And this is just such a high number among folks that are uninsured at childbirth, as well as those that are uninsured postpartum, where, 2/3 of folks that are uninsured at the time of childbirth were never screened for abuse. It points to the specific groups that suffer the most from lack of detection and lack of screening, and toward whom we need to direct both prevention services and support. So those are the quantitative findings. And it's really important to also understand what is happening behind these numbers, because these numbers rely heavily on on the questions that were asked of people who were in the perinatal period about their care and their experiences at that time. Another thing that we did was interviewing key informants who were mostly staff members from 15 different victim support and advocacy organizations. We talked to 5 nationally serving policy and advocacy service organizations and 5 state-based coalitions. Those states are listed here. We also talked to 5 direct service organizations that focus on rural communities in 4 different states. We identified organizations through online searches, through snowball sampling, and a publicly available list of grantees through the Office of Violence Against Women, the Rural Sexual Assault, Domestic Violence, Dating Violence, and Stalking Assistance Program, and their rural-focused program. And we basically tried to talk with different types of service organizations to share our numbers and information that we found in our research, and to understand how those numbers make sense to them and what they see as the greatest challenges and opportunities for addressing intimate partner violence around the perinatal period for rural residents in particular. I want to share one perspective that, well, I'll move on and move forward. So I want to share some of the words that they shared with us. And the first piece that I really want to share with you relates to the concept of power and control and the challenges that creates for the folks that are doing the work to support prevention and support services for intimate partner violence. I think there's also this real reality in our movement that domestic violence and sexual assault do not exist in a vacuum, and they exist because of the societal structure we've created, which is a patriarchal structure, a structure of oppression, a structure where we're not talking as much about gender-based violence as we're talking about power-based violence. People that hold power, are perceived to have more rights to behave the way they want to. And how do you hold power accountable when you're not in power? Other words that I want to speak into the space that speak specifically to the risks faced by folks in rural communities. One of the greatest challenges for clients is being in a rural area. Rent is outrageous compared to wages, so many victims choose to stay with their abuser for the lack of financial resources elsewhere. If there are no other homes to go to because there are housing shortages, if the rent would be unattainable, that can create more difficult circumstances for rural IPV victims. So now I want to transition us to a brief discussion of the implications of this research for clinical and policy efforts, and to improve access to safety, hope, and healing that all rural residents and really all people deserve. There are barriers to universal abuse screening. We're seeing the data that show that, and some research already shows that. For clinicians, barriers to abuse screening may include lack of knowledge about how to screen for IPV, discomfort in screening for and discussing IPV with patients, little time to screen for IPV during healthcare visits, and a lack of accessible referral resources for people who do screen positive. That may deter clinicians from asking about IPV. These barriers may be amplified for patient-clinician interactions in rural settings, given access challenges such as distance to care, workforce shortages, and among rural IPV victims at the greatest risk for not being screened. That includes unmarried birthing people, younger birthing people, lower income, Medicaid beneficiaries. It's really important to think about strategies that address these barriers to achieving universal abuse screening. These policy efforts could focus on universal screening during care visits and processes and procedures in place in clinical settings that adopt this, as well as targeted support for the at-risk people in rural communities before, during, and after childbirth. Some of those resources and screenings are listed here. I think supporting clinicians and having the skills that they need to comfortably ask questions about intimate partner violence and to understand the dynamics of violence and abuse in around the time of pregnancy is also important. I'd like to bring the words of our key informant interviews into this space to help us to, again, think about those implications and how to move forward. There's no statewide statute in our state for mandatory training for healthcare professionals on domestic violence or domestic violence screening. There's still large numbers of professionals in our trainings who said that they've never received training on domestic violence. So I think there's a lot of missed opportunities for screening survivors and responding to domestic violence. I think having that in policy would be really helpful toward rural victims and pregnant and postpartum people. Additionally, when we think about the policy space, health insurance coverage has included abuse screening without cost sharing since the implementation of the Affordable Care Act in 2010. But ensuring access to health insurance coverage and access to care in the preconception and postpartum periods can help facilitate financial access to care and thus the opportunity for screening during those time periods. Access to healthcare coverage, though, doesn't necessarily mean access to care. So we have to make sure that both financial access in terms of do you have health insurance coverage, as well as physical access in terms of distance to care, innovative care models, and making sure that people have access to continuous health insurance, especially those folks with Medicaid coverage. Investing in targeted communities is also an important potential implication. Current efforts to extend Medicaid postpartum coverage may be helpful and should be maybe up for discussion. And so this is one of the angles to be thinking about as we move forward with policy discussions. But targeted support for people in rural communities may also be helpful for not just screening, but also for some of the prevention and helping people leave situations that are not safe. Here are the words from our interviewees. Just bolstering the funding and services that are available in rural places would support the health and safety of rural IPV victims. This includes access to affordable housing and jobs that provide living wages, access to childcare, access to other things that the federal government can do, like tax credits for children or low-income individuals. Really speaking to the broader policy concerns, like, yes, we're talking about health insurance and healthcare access, but also just about being in safe and livable communities. Policy implications for prevention. So we've talked a lot about screening and universal screening. And it's important to think also about preventing abuse in the first place where it's possible to do that. Our research revealed inequities in the experiences of intimate partner violence among rural residents, including some of the highest risks among Indigenous folks and among folks that are insured by Medicaid. Prevention efforts are needed in Indigenous and tribal communities and should be of and for those communities. Uninsured insurance coverage differences could be addressed not just when we look at postpartum, but also looking at Medicaid-based prevention and support programs or investment in those that are reached through Medicaid in innovative ways that may also address prevention by helping, for example, people who are married to an abusive partner be able to access their own health insurance and not having to stay in the marriage in order to be able to access healthcare services. Prevention research, we don't have is like, this is an area for further work. There's some good, documentation of victims' services and batterer intervention programs. That's terminology that's often used in the field. And healthcare provider trainings, requirements, and support. So this is like what programs work for harm reduction, but actually preventing intimate partner violence is a larger task and a very, very important one for for us collectively as humans, not just for us as researchers, but I think it's also something to be thinking about. In the meantime, though, we do have some harm reduction, some evidence on harm reduction that could be helpful to implement. again, let's bring in the words of the folks that are leading these services and supports in rural communities. There's nothing like listening to women because their lived experience is just so vital. There's just so vital, and it has to be heard. The foundational layers of structural oppression and structural inequity end up impacting survivors in so many ways that approaching this kind of violence from an individual paradigm, aside as we often do in healthcare, really just only leaves people to continue to experience harm, generationally speaking, and at a community level. Intimate partner violence is too common, it's incredibly dangerous, and many victims aren't ever even screened. Intimate partner homicide is a leading cause of maternal mortality, and every pregnant person who is physically, emotionally, or sexually hurt by an intimate partner deserves, at the very least, to be asked about this during their healthcare visits, and ideally also to be supported and safe outside of a healthcare setting. Maternal mortality is a crisis in rural communities, and intimate partner violence is a contributor. Policy efforts for addressing intimate partner violence among rural residents could focus on universal abuse screening during healthcare visits and continuous health insurance coverage, as well as access to services and targeted support for people that are at greatest risk in rural communities before, during, and after pregnancy. I am from the Anishinaabe people, and our language is called Ojibwe Ojibwe-Mon. And to say thank you, we say miigwech, chi miigwech. So I say thank you to each of you. I've provided some resources here on domestic violence and support services, which I think are important now more than ever. And as well as a link to our research center's website, where we have some of this work is published, as well as our other work on rural health. And we have a few minutes for questions. I welcome any questions that you have. And again, thank you very much for being here.
Thank you so much, Dr. Kazumanel. Thank you for sharing such important research. And you provided a huge amount of information. So thank you for bringing this into our community here. I do want to encourage, we have a good number of people online, and I have heard directly from folks about how excited they are to learn about your work. I do want to encourage people to post some questions if they have questions about what you've presented or implications of the work. I'm happy to kick things off. I have a number of discussion questions I would love to ask, big and small. I may just start in the middle, thinking about, obviously IPV, you demonstrated that it is a problem in urban and rural areas, but there's a greater burden in rural areas. And I'm wondering, in the context of, both having the screening happen and also what happens after someone screens positive, you know, how different is what's the services and resources needed in a rural setting? How different are they from, what we might see around screen positive, response to screening positive in an urban setting? I know you think more holistically about this. What does the broader context look like when a patient is identified as experiencing intimate partner violence? And you can take that whatever direction you might want to go.
Absolutely. Thank you so much for that question. And thank you for framing it in the context of like a person who screens positive and the clinician that's sitting there with that screen being like, what is the next step? I will share a personal anecdote related to that, which was I think it's similar for screening for postpartum depression or something, like any of these screens that you have where like this person isn't okay and needs help, and they have a little baby or they're pregnant, right? I had the experience after my second child was born. I was uninsured at that time. It was after my postdoc and before I started a faculty position. I was in the fortunate position of knowing I would have health insurance someday, but I was uninsured at that time. And I went in for her 2-month visit, and the pediatrician screened me for postpartum depression. And I recognized it. And I said, like, I actually noticed that their forms were like those kinds of forms that have been photocopied over and over. And I said afterwards, like, you can download the form here, like here's the website. And they were like, wait, what now? They're very surprised they did not expect the uninsured woman was falling apart to know, but I did. And I said to them, like, and I said to them something like, oh, well, what referrals do you give to people who screen positive? And the nurse who had screened me was like, oh, no, 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 you didn't screen positive. And I was like, no, I know. But if I had, what would you? And she was like, oh, well, is it, she looked just shocked. She was like, we don't really have we don't have anything for uninsured people. Like, we don't know what to do, And it was such an interesting moment for me to like feel that. Um, and and to feel it for her too, because it was hard for her to be honest and tell me that. And I think that's a version of what happens, especially in rural settings. In urban settings, we have local shelters, we have, victims advocates and support people and networks. And like those, they are on a shoestring, but they exist. There are places you can physically go. And in rural communities, it is more like there isn't an organized way to even get someone a bus ticket to get down like to the closest shelter that they might need to go to. And then you have to like leave your whole life, and do you leave your job, and what about your other kids or your cousin or whatever? And so it's really, really, really difficult without an infrastructure in place, even the basic victim support services infrastructure. And this is sort of what we heard when we did these interviews, where they're like, well, they wind up like, people burn out in this field really fast when they're doing rural work, because they are the like person whose cell phone number is on the doctor's offices in 7 different counties. And they don't know what to say when they get that phone call. Like, if they can scrap together the money to find someone to drive them, away, but it's very, very difficult. I hope that helps. Does that help a little bit, giving some context? I don't know if there are other questions. I don't think I saw anything come in.
Yeah.
Are folks shy today, or just, I also understand it's like, it is such a week. It has taken a lot for me to like gather the energy to say these things to you all
Yes.
today. So if everyone needs to just like take it in and rest, I also do understand
We
very
have another
much.
question and
Great.
explicit appreciation, and thank you for your response. Yeah, it helps to flesh out just like what does it actually look like in this setting that many of us don't study. So thank you.
Mhm.
Um, yes, my colleague, Dr. Mara Decker, says, thank you so much for an interesting and informative presentation, particularly from the systems and policy level. What do you think the role of the criminal justice system may or should be in this
Mhm.
context?
Absolutely. So there is a huge challenge with both prevention and victim support services and how that interacts with criminal justice, because there are a lot of problems with the criminal justice system, and the assumptions that are made about people that report experiencing violence, as well as the interaction between the system and both potential victims and those who are like alleged perpetrators or who are perpetrating. And I think in many communities, in many communities, I'm going to speak specifically about Black and Indigenous communities, there is a hesitation to involve the criminal justice system, even when people are in danger, because of the further harm that system can be in terms of interacting. The same challenge with that healthcare folks have, like the good-hearted folks that are coming into a domestic violence situation that are trying to diffuse the situation, they don't necessarily have a solution to that. They can try to ask if they would like to press charges, but usually what happens is that doesn't happen right at that moment. Sometimes the person is removed from the situation, but more often than not, the situation is diffused, and then the law enforcement official leaves. And when you are in a relationship like this, it is a dynamic that is constant, and these like brief interventions can actually make you at greater risk. Even things like filing an order for protection or a domestic violence protection order usually require that you reveal information to that person about, like, you have to file it with your address of where you are, and then they know where you are. There are so many pieces of this that create greater vulnerability. So we often think, like, why don't they just ask for help? Why don't they go somewhere? Why don't they call the cops? there are a lot of reasons why folks don't. And even when they do, there's a lot of challenges for the folks in law enforcement who are trying to provide support. There have been some studies done showing that there is I don't remember the numbers right now, but there's a measurable portion of people that are law enforcement officials that have charges or have been um, charged with committing domestic violence. And so there's a problem there too, as well.
Thank you for that response. I appreciate all the nuance and complexity baked into all this. We are unfortunately at time. There was another question that came in about what else you're working on, but we'll try and follow up with you. Maybe you can come back. Thank you for tackling such an important topic and for sharing it with us. We really appreciate it, and best of luck with your work. Do come back.
Thank you. Thank you, Sarah. Thank you all so much. Chi miigwech, everyone. Take care.
Thank you.
Bye.